Hi, everyone. Welcome back to another episode of CHD Unpacked, a podcast about living with congenital heart disease. This podcast is brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we'll be unpacking the topic of medical technology advances in fetal cardiology. We're very honored to be joined by today's guest, Dr. Mike Seed. Dr. Mike Seed went to medical school at the University of Newcastle upon Tyne in the UK, where he also undertook basic specialist training in pediatrics. He switched to radiology for his residency training at Leeds before moving to Canada for fellowships in cardiac imaging and pediatric cardiology at SickKids. He was appointed as a staff cardiologist at SickKids in 2011 and became Division Head in 2017. He was appointed a professor of pediatrics at the University of Toronto in June of 2023, where he is also a member of the Institute of Medical Science and the Department of Physiology. He is also a senior associate scientist in translational medicine at the SickKids Research Institute. His clinical work at SickKids includes cross-sectional cardiac imaging and fetal cardiology. He is also a member of the single ventricle team. His research is in fetal and infant circulatory physiology and brain development, and he has been an active participant in the Cardiac Neurodevelopmental Outcome Collaborative since 2015. He's also working on a swine model of the artificial placenta. He has published 158 original journal articles and 12 book chapters. Please join me in welcoming Dr. Mike Seed. Hi, Dr. Seed. Welcome to CHD Unpacked. Thank you so much for joining us today.
Thank you very much for inviting me.
So today we're going to be talking about medical technology advances in fetal cardiology. To kick it off, can you please just tell us a little bit about the scope of your practice?
Yeah, sure. I'm a pediatric cardiologist, and my clinical work includes cross-sectional imaging in children with heart disease, as well as fetal cardiology. And I also participate in some of the general pediatric cardiology work of the division.
Great. Thank you so much. Can you explain a little bit for the audience how fetal cardiology has evolved over recent years and how this has kind of influenced health outcomes for infants with congenital heart disease?
For sure. So fetal cardiology helps us because we can prenatally diagnose congenital heart disease, and we can also treat some conditions that would be dangerous for the fetus. The main thing really is to be able to give families information about the heart disease that is detected, and help them prepare for what's going to happen when the baby's born, what they might expect in the long run. And that also helps with, making sure that the baby's delivered safely, and that appropriate plans are made for any treatment that might be needed, soon after birth.
Right. And what are the different types of imaging modalities that might be used to help diagnose CHD and characterize how complex a lesion is, or what kind of dangers we might expect?
Most of it is with ultrasound, and that has become a very sophisticated modality. It's the same technology that's used for doing echoes in postnatal patients, and of course what's used for looking at the rest of the fetus when obstetric ultrasounds are being performed. Mm-hmm. But a fetal echo really is focused on the fetal heart, and that includes imaging the anatomy of the heart. These days, we acquire movies of the fetal heart so that we can see heart function and the valves opening and closing and so on, and that gives us a very accurate idea of the anatomy of the heart. And then the echocardiogram also uses Doppler, which takes advantage of the movement of blood through the heart to get information about about physiology of the heart and how that's affecting the physiology of the fetal circulation. So looking at blood flow patterns and velocities and so on, then we can get even more information about the impact of the heart disease. So that's the main imaging modality we have, and it's been integrated, and an examination of the heart has been integrated into the obstetric screening that is done for all pregnancies, that are receiving normal antenatal care. And so that's how much of the congenital heart disease is first picked up, is during screening that is done at about halfway through the pregnancy, around 18, 19 weeks is when that anatomy scan is done. And if there's any suspicion of a problem with the heart, then an additional detailed fetal heart scan can be undertaken, which is done in a variety of settings. That's if a diagnosis is made, then we would frequently follow a patient closer to delivery and watch for how the heart disease is evolving and make a plan about delivery. There are one or two other imaging modalities that have been mainly used in research settings. One of them is a very specialist technique for looking at fetal heart rhythms that uses a sort of magnetic field. But the one that I've been interested in and involved in the development is MRI, and fetal MRI has been around for quite a while. Mainly, it's been used for imaging other organ systems in the fetus in the past, and particularly looking at the central nervous system, where the capability of MRI to sort of distinguish between different tissue types due to its sensitivity to tissue characterization has been helpful. The development of fetal cardiac MRI is relatively more recent, and that really reflects the fact that there have been some significant technical challenges or hurdles to overcome to actually get decent images of the fetal heart, because MRI actually typically requires the use of the ECG to actually collect the imaging and synchronize the acquisition of images. And that has not been typically available for fetal imaging. The fetal ECG gets mixed up with the mother's ECG signal, and so you can't use it. But over recent years, some alternative approaches to triggering the imaging to the fetal heart rate have been developed, and also some ways of overcoming artifacts that are due to fetal motion. And that's what's really helped to develop a reasonable approach to doing some fetal cardiac imaging. And, we're just in the early stages now of understanding how MRI might be able to help with fetal imaging and in the setting of heart disease. And, that's what some of the work that we've been doing at SickKids.
Okay. And are there specific types of congenital heart disease that you anticipate MRI will be more useful for identifying as compared to only using an ultrasound?
For sure, yeah. I mean, it's not. I don't think its role is going to be so much in the identification or diagnosis of the heart disease. I think that is pretty successfully done with echocardiography, and it's most useful to do that earlier on in the pregnancy when MRI is really very challenging. The strength of MRI, I think, is in assessing the fetus later on in the pregnancy, when sometimes ultrasound can become more difficult because there's not as much fluid around the baby, or the bones in the baby's ribs might be obscuring the ultrasound beam, or the baby's chest is right down in the pelvis, and it's hard to see. So as the baby's getting bigger and moving less, that's actually a great advantage for the MRI, because we don't have such difficulty seeing these really small structures, and there's less movement to degrade the imaging. So that's sort of where I think it may have a role. And what we've tried to do is see whether MRI might provide some different sorts of information than the ultrasound, and so we've explored some measurements of blood flow and oxygen levels that we can obtain with MRI, and to see if they could help, particularly in the setting of a fetus that's really got severe heart disease, and we might even be considering, some kind of fetal treatment. So the more the kind of complex end of the spectrum of heart disease, fetuses that we're worried that they may get into trouble even in the delivery room, that sort of situation where really you want as much information as possible about the physiology or other aspects. Some examples of those include single ventricle fetuses where, for example, if there's obstruction of pulmonary venous return, you can get lung disease occurring even in utero. Hyperplastic left heart syndrome with restrictive atrial septum. What we've learned is that MRI actually can be used to visualize pulmonary vascular disease, actually, and dilated lymphatics in the lungs. And that finding actually, on its own has important prognostic value. And then in babies with transposition of the great arteries that, occasionally can be very sick in the delivery room, we've been looking to see whether MRI could help us predict, what the oxygen levels are going to be at the time of birth. And in both those situations, we could potentially offer a percutaneous fetal intervention that might stabilize the baby at the time of birth. So those are two, that we've been working on. And another is perhaps, just any situation where you really just can't see the baby's heart at all for some reason. Occasionally this happens with it very late in the pregnancy, as I mentioned, with, for some reason the ultrasound windows are hampered, and just got an alternative way to make a diagnosis of the anatomy.
Mm-hmm. And how available do you anticipate this will be for different hospitals? Is this something that you anticipate will only be restricted to larger centers like SickKids for quite some time, or how do you think that will be disseminated?
Yeah, so I have wondered that myself, and for a long time there were very few centers trying to do this at all, and I do think that those indications that I was discussing about, more severely affected patients, those are typically being followed in tertiary centers, or centers that are having a lot of experience with looking after patients with congenital heart disease, like places like SickKids. But I have noticed recently that there seems to be a lot more interest in this technology in a variety of settings where it may be people may be exploring it almost more as a screening test and so on. And that's been largely facilitated by the development of some new technology that employs an ultrasound signal to do the gating, the triggering of the imaging that I mentioned. And there's a device, a commercially available device now on the market that people can use to do some fetal cardiac imaging. And it's really been remarkable to see the uptake of that. And suddenly, many centers are doing this. And so I'm very optimistic that will lead to, faster rate of kind of discoveries about what the applications might be.
Mm-hmm. Well, it's incredible to kind of see the progression of the way that congenital heart disease used to be missed years and years and years ago, and the fact that ultrasound is now so widely available and used, and now we're moving on to more sophisticated modalities of imaging, and being able to gain so much more detailed information as you were describing, and anticipating delivering a child with transposition or a single ventricle disease. So it's incredible to see that transformation. And you were mentioning also the fact that MRI can give information about other organ systems, and just knowing that brain development can also be something that's influenced, or impacted rather, by congenital heart disease. Can you comment on how MRI can give us more information about that as well?
Yeah, absolutely. Yeah, so as you mentioned, that we're learning about brain development in congenital heart disease, and some important discoveries identified that there were probably alterations in brain development starting even before birth, and that there was always a sort of suspicion that might be something to do with the circulation being different, and how the brain was being supplied with oxygen and other metabolic substrates to grow. And that was really one of our main motivations to try and develop the technology, was to look into that question. And the combination of being able to do careful sort of brain imaging, looking at brain growth and development, with these circulatory measures like cerebral blood flow and oxygen delivery, has really confirmed to a large extent that the delays in brain development that we see in newborns with congenital heart disease probably are due to the abnormal cardiovascular physiology of that is caused by the heart disease, and that these are actually associated with early developmental delays in patients with more severe forms of heart disease. It's a huge topic, and one that I feel we still have a relatively poor understanding of the whole area, but I think that it's actually increasingly recognized that fetal development is probably part of the story.
Mm-hmm. And is there certain ways that we can kind of screen for that with MRI imaging? And if we are able to detect something before a child is born, is there anything that can be done about it, to potentially intervene on some of the changes?
Yeah. So there's starting to be some results of research studies that suggest that things like the size of the brain during during fetal life may be predictive of development, and also those circulatory parameters like cerebral oxygen delivery and blood flow are somewhat predictive. On an individual patient basis, it's I think it's still very difficult to predict what a patient's neurodevelopmental outcome is going to be like. And there's so many factors occurring after birth that are important, as well as issues that are probably present even before fetal, the fetal development, like genetics, and then environmental issues that to do with a patient's social environment and education and so on. And it's very encouraging to see. I think that most patients with congenital heart disease now are experiencing excellent neurodevelopmental outcomes, and that but as you say, there may be some possibilities for improvement. And an example that we've observed is in patients with severe Epstein anomaly, where we've actually documented a reduction in cerebral blood flow in utero due to that that very unstable circulation. And so the fetal therapy that is being offered to those patients, where non-steroidal inflammatory medications given to the mother will help to restrict shunting through the duct in utero. Actually, we've observed a stabilization of the circulation and improvement in cerebral blood flow. So whilst I don't have proof that actually improves neurodevelopmental outcome, it makes sense that it would. And there are people exploring other sorts of interventions. Our own group has looked into supplemental oxygen in quite a lot of detail, and my our conclusion is that probably doesn't help with fetal brain development, not because the oxygen wouldn't be helpful if it was going to the brain, but more because it seems to result in a reduction in cerebral blood flow, and it vasodilates the lungs. And so there are probably some sort of off-target effects of the oxygen that kind of cancel out the beneficial effect. So it's a difficult question. It's a difficult subject to find ways of improving fetal brain development. There's quite a bit of work going on that's linking maternal stress to adverse brain development in fetuses with congenital heart disease, and interventions to try and improve the mother's mental health and so on are being investigated. And some other drugs are being looked at. One that the Philadelphia group have tried is progesterone, which is thought to be neuroprotective and prevent preterm birth, which is important in congenital heart disease. And they saw some benefits in a subgroup of patients in their study. So, there is quite a lot of research going on in this area, and I expect at some stage we're going to learn to ways of protecting the perinatal brain better than we have in the past.
Right. Yeah, it sounds like it's being approached from many different angles and looking at all different contributing factors, which is exciting to see for the future what that might yield in terms of new information. But I anticipate some of this research might be quite long-standing, given that neurodevelopment is something it's a bit of a waiting game, I guess, to see.
For sure, yeah, these studies really need very long follow-ups because we don't currently have very good markers of brain development, even on imaging, that are very predictive. So ideally, you really want to, for a fetal intervention, you want to know what the adult's
Right.
neurodevelopmental, spinal developmental status was. So you'd have to have a study that lasts 20 years, and that's quite a challenge. But with some of these big networks that are collecting registry data, I think that's probably going to be the way that we get answers to some of these questions.
For sure. So exciting results to look out for.
For sure, yeah.
Just to kind of switch gears into other research that you can speak to that you currently contribute to pertaining to artificial placentas specifically. For our audience that might not be aware, can you explain what a placenta is and the purpose that it serves in a pregnancy and how that might impact the development of a baby?
Yeah, for sure. I mean, it's an interesting organ that's often forgotten about, I think, but it's essential, of course, for normal fetal development because it's the organ that is responsible for the exchange of nutrients and oxygen between the mother and the fetal circulation. It's where their blood vessels from the mother and the fetus come very closely together, so that nutrition and gas exchange can occur between their circulations. And a healthy placenta is required actually for normal growth and development. And abnormalities of placental development are not uncommon, and frequently result in poor fetal growth, and may even threaten the survival of the fetus.
Okay. And if this is the case, what kind of things can be done to intervene, and what kind of outcomes would you expect for a baby?
For sure. So, I mean, there aren't many treatments for a baby that's being affected by placental insufficiency. What is typically done is that the fetus would be monitored carefully, and the goal always is to achieve delivery as close to the normal time as possible. But sometimes the placental insufficiency is serious, then certain features from the fetal monitoring might prompt a preterm delivery to be planned, and then to sort of prevent the fetus from coming to harm, knowing that preterm delivery, of course, has its own risks and health problems that are associated.
And when a baby is born premature, what are some interventions that are done to help them thrive after and hopefully be healthy once they're discharged from hospital?
So, the important issues are that, preterm baby is not developed to fully for, extra uterine survival. And, the most critical aspect is that the lungs are not ready to breathe and take over the role of gas exchange that the placenta has been doing. And this is what really limits, survival outside the womb in very preterm babies, is that they simply can't oxygenate or do gas exchange, because the components of your lungs that are responsible for gas exchange simply haven't grown yet. And so, towards the lower limit of viability that is currently at around 22 weeks gestation, these fetuses are currently managed with mechanical ventilation, almost as soon as they're born, to try and assist with gas exchange by and supplemental oxygen is given as well. These infants are not able to control their temperature, so they have to be kept warm in an incubator. They're not ready to start absorbing nutrition from their gut because it's immature. So they will get parenteral nutrition directly into their blood. That there are various other aspects of kind of intensive care that are brought in for various complications of preterm birth that occur to other organ systems too.
Okay. And are there any long-term adverse outcomes if a baby were to be on, for example, a mechanical ventilator?
For sure, yeah. So the actually just the process of starting to breathe air causes some arrest of normal lung development, and the ventilator itself, the pressure that is introduced by the ventilation, and also the oxygen itself, can be toxic to the lungs. And so one of the major complications is a condition called chronic lung disease, which is sort of a combination of of being born preterm, and then the treatment that is required to survive that. And that may require a patient to be needing supplemental oxygen for some time after even after term, and that can be associated with sort of chronic problems with lung function, even in later in childhood or in adulthood, an increased risk of asthma and that kind of thing. And the other really critical issue is that brain injury is quite common again in the setting of preterm birth. The sort of dramatic changes in circulatory physiology affect cerebral blood flow, and there are injuries like bleeds that occur to quite fragile blood vessels in the brain, as well as potentially sort of toxic effects of changes to the circulation and oxygen levels on the developing brain. So a lot like congenital heart disease, actually, it's relatively common to have some issues with neurodevelopment following a really preterm birth, and those are needing a similar sort of approach in terms of therapies for that, and follow-up of development to try and offer interventions to help with child development.
Sure. And do you see an association with babies that are born preterm and those that also have congenital heart disease? Will someone potentially have kind of the uphill battle of managing the congenital heart disease as well as the sequelae of all of the things that come with being born preterm?
Absolutely, yeah. There's an increased risk of preterm birth if you have congenital heart disease, and there's that they're actually just preterm birth in some respects is associated with things like a patent ductus, which is a type of congenital heart disease in a way, but certainly the combination of the two is very significant, because the abnormal physiology associated with congenital heart disease sort of compounded by the issues that are going along with immaturity of the lungs and the heart muscle and so on, that can be a real struggle for this preterm baby. And the types of treatment, surgical repairs and so on that we do in term babies, not always possible in a preterm baby, because they're just too fragile to undergo heart surgery. And so, then they're sort of at risk of these kind of injuries to other organs that are occurring because their circulation isn't stable. So, we know that as birth weight and gestational age at birth go down, then the mortality from congenital heart disease increases dramatically. And similarly, we're learning that neurodevelopmental problems are much more common in preterm babies with congenital heart disease than babies born at term. So yeah, it's a really important area, and still one in which we've got a lot of work to do to get the same kind of outcomes that we do in fully grown term babies.
Right. And it really seems like those latter weeks of development can have a really strong impact on the outcomes for a baby in terms of all these interconnecting factors of brain development, other organ development, the risk of congenital heart disease, and then the subsequent interventions that might need to take place because
For
of that.
sure, yeah, for sure. Congenital heart disease surgery has come a long way, and the idea of neonatal heart surgery is relatively modern, and has transformed things. But the next frontier, I think, is learning how to treat these even smaller babies and get the same kind of outcomes.
So, along the lines of trying to find new technology in order to help infants in this position, can you talk a little bit about your research with artificial placentas?
Yes, for sure. So it's a simple idea, really, that a, a fetus at 23 weeks, say, would be more appropriately cared for in an environment that simulated the in utero environment um, than extrauterine life, and relying on mechanical ventilation to breathe. And in fact, there has been research into this concept of sort of artificial womb technology, if you like, since the 1950s, actually. And there's really only been animal experiments so far, but there's been surge in interest in that approach as a way to treat extremely preterm babies over the last 10 years or so. And I think the change has come because of improvements in technology that would be needed to create an artificial womb environment, particularly the oxygenators that we use actually to do neonatal heart surgery and that kind of thing. Um, are getting closer to having a similar physiology to an actual real placenta, in that they've got smaller, and the resistance to blood flow through the oxygenators is become very low, and the performance of the oxygenators in terms of their ability to exchange gas from blood is now very good. And so um, a group in Philadelphia actually reported in 2017 remarkable results at being able to achieve um, really quite normal fetal cardiovascular physiology for extended periods of time, up to a month, on an artificial placenta, artificial womb device. Preterm lambs, they were actually essentially sort of doubling in size and developing normally, showing none of the injuries that we characterize with preterm birth treated in the conventional way. And when we saw that work, we were quite inspired to try and reproduce it, and started a laboratory at SickKids, um, and we've been learning how to do it. We haven't had the level of success that has been reported in those sheep. We've used a pig model, and we sort of started with miniature pigs that we thought would be a good model because they were very similar in size to the extremely preterm human infants that we think are probably the obvious first target for potential for this therapy to be applied. And our experience was that it was much more difficult than we expected to, first of all, to actually create a connection between the fetal circulation and the oxygenator, because that's one component of the system, is to essentially put plastic tubes into the blood vessels in the umbilical cord so that blood can be circulated through the oxygenator via the umbilical cord. And then the second component is that the fetus would be kept in a fluid environment so that it doesn't start breathing air and sort of transition to a postnatal physiology. And so the other component really is fluid incubation system. And what we found was that it was really quite challenging to achieve that connection. And then when we learned how to do that, we found that the circulation was not at all like in a normal fetal circulation, and the animals quickly developed heart failure actually. We're fairly sure that the reason for that was that it was creating abnormal loading conditions on the fetal heart to actually send the blood around this external oxygenator circuit. And so our efforts have been to try to make the artificial placenta more like a real placenta. And similarly, other groups that are working on this problem have recognized that there are going to need to be modifications in the design of the equipment that is used for normal term babies to be suitable for a much smaller preterm baby. And so the groups that are reporting some success with smaller sheep now, sort of smaller animal models, it's when they have actually been able to partner with oxygenator companies that are able to make them special devices. And I understand that a clinical trial is being planned by the group in Philadelphia, and we have heard that the Food and Drug Administration is considering an application for that. So that's sort of where things are with our artificial placenta research.
I was going to ask you how close we are to transitioning from an animal model into a human model. Do you know how long the process would take to potentially get approval to start that trial?
So I'm not aware of how close things are, but I suspect that we will be hearing in a very near future that that this has been approved and that they're going to go ahead.
And how would you go about counseling families who, because it's such a new form of technology, how would you counsel them on the risk benefit ratio of potentially trying something like this versus the risk of not trying it and kind of facing the challenges of prematurity?
Yeah, I mean, I think that it's when you're in a tough position that you're willing to try new things. That in these really extremely preterm infants, we know that the risk of complications is pretty high still, and so I think that's going to be where the initial efforts are made to see if a benefit would be conferred by that technology. I mean, if the patient is not doing well on the device, they can quickly be converted to conventional treatment. By simply disconnecting them from the device, if you like, and switching to normal treatment. I think from counseling perspective, as you mentioned, that in situations where things look quite risky with conventional treatment, then it's reasonable to try something different.
Right. And if this is something that becomes more developed and it is available at larger hospitals, what would this mean for infants born with congenital heart disease? How would this change their outcomes in the future?
Yeah, that's one of the reasons why I got interested in it. The main application will be in preterm babies that don't have heart disease because they're much more common. But as we were discussing a bit earlier, that combination of heart disease and preterm birth is very risky. And so it could be that is the way to support a baby that's too small to have a heart operation, but is potentially gonna get into trouble because of the heart disease and the combination of heart disease and prematurity. Could you actually provide a setting for improved growth and maturity without any injuries, and then just get to the right age to undergo their usual treatment.
Mhm. So it seems like it gives us more options for the tough situations where there's risks either way. It just kind of gives another avenue in order to support those infants.
Absolutely, yeah. I mean, I think uh, the issue will be that don't always know that the baby has heart disease. I mean, the fetal diagnosis that we talked about earlier on, helps with that, but and then don't always know that a premature delivery is going to happen either. So, actually, that's going to be the challenge, is that uh, getting onto the artificial placenta really requires that it happens at the time of birth, really in within seconds or minutes
Oh,
of the baby being born. They need to be they will need to be put on the system, because once they actually start breathing and transition their circulation to a postnatal circulation, I don't think it'll be possible to go back to the sort of fetal circulation that would be needed for the artificial placenta or artificial womb.
yeah. So once this comes into practice, it would really only be available for um, mothers that are delivering at a tertiary care center where this is planned and advanced, and it can kind of be set up before the delivery.
Yeah, so about a third, I think, or half of preterm deliveries are sort of predictable. Either there's a problem with the placenta, or the membranes rupture, and there's a risk of an infection, and it I think it that there are, and then of course there are some pregnancies where there's some sort of congenital abnormality that's going to be important. And so those are the sorts of pregnancies that I think would be suitable for this. But there are still going to be preterm babies that we just can't anticipate that, and it'll be, by the time the baby's born, it'll probably be too late um, to do the artificial placenta.
Well, it'll be very interesting to see the outcome of this trial that will hopefully get approved soon, and just kind of see where this technology takes us in the future.
Absolutely, yeah. No, I think it's one of the most exciting developments in perinatal medicine. And it makes a lot of sense. I think it's, but we're yet to see whether it's actually going to be possible. The animal models are not always perfect models for humans, and you know, um, there's a lot of uncertainty, I think, still around, whether it's going to be possible, but certainly the animal experiments are getting more and more promising in terms of the feasibility.
Absolutely. Yeah. And I think it's what we have to work with in terms of the starting grounds for developments in medicine, and hopefully it can translate into saving more lives in the future, and sophisticating the technology a bit more.
Yeah, yeah.
Well, thank you so much, Dr. Seed. It was great to hear about these new advances in technology, and hopefully we'll do a follow-up episode in the future once we have
For
some more
sure.
information and more technology to talk about. So, from everyone at CCHA, thank you so much for joining us today.
You're very welcome. It was a real pleasure, and thank you again for inviting me.
Take care.
Bye.